Welcome to the 2020 Vermont Statewide EMS Protocol Update Medical Policies. The DNR COLS protocol has been updated to allow for verbal order clinician signatures. All out-of-hospital DNR orders are mandated to be on the Vermont Department of Health DNR COLS form. If the patient is in a healthcare or residential care facility, then the DNR or COLS order can be documented in the patient's medical record. To be valid, DNR COLS orders must be signed by the patient's clinician. With this update, a verbal order documented with the clinician's name and signed and dated by the patient's nurse or social worker is also acceptable. There have been many questions about the police custody protocol, which we will address in this update. The protocol has been updated with clarifying text and to reflect current Vermont statute. First, it is important to understand the difference between protective custody and police custody. Patients under protective custody are not under arrest. Protective custody is a civil status in which an incapacitated person is detained by a law enforcement officer for the purposes of assuring the safety of the individual or public or both, and for assisting the individual to return to a functional condition. There are two different situations where a person might be placed under protective custody: patients with psychiatric emergencies and patients with acute intoxication and incapacitation by drugs or alcohol. Patients with a psychiatric emergency who present an immediate risk of serious injury to themselves or others should be transported to the emergency department for an emergency examination. If the patient does not agree to being transported by EMS voluntarily, consult with local law enforcement and mobile field crisis staff if available. The patient may be placed into protective custody and transported to the emergency department for an emergency examination, EE, but the police will first have to obtain a warrant from a superior court judge before the patient can be transported. Patients who present with evidence of incapacitation from alcohol or drug use may be placed into protective custody by the police and transported to the emergency department if they require medical evaluation. In summary, there are two types of protective custody: psychiatric and intoxicated. A person with a psychiatric emergency will first require a warrant from a superior court judge in order to be placed into protective custody and transported to the emergency department for an emergency examination, EE, unless they go voluntarily. An intoxicated person may be placed into protective custody directly by the police and transported to the emergency department if they require medical evaluation. Police custody, on the other hand, means a person is under arrest. Patients in police custody who require medical care do not have a choice and should be transported to a medical facility. Sometimes the decision algorithm to transport a patient is not so black and white. If you feel a patient requires protective custody for either psychiatric or intoxicated causes, consult with your local law enforcement officer. If law enforcement refuses to place a patient into protective custody at the request of EMS, or if police and EMS disagree about whether a patient in police custody requires transport to a medical facility for further assessment or treatment, online medical direction must be contacted and a law enforcement supervisor should be requested for guidance. If medical direction advises that the patient needs to be transported to the emergency department, but you are unable to do so, document the circumstances carefully in your chart and communicate with medical direction. Refusal of care. Refusal of care represents one of the most high-risk medical legal activities that EMS engages in. Following the refusal of care protocol carefully will help ensure the best standard of care for the patient and protect the EMS crew as well. 2020 updates to the refusal of care protocol include moving the patient non-transport algorithm into the protocol and incorporating all questions in a consistent format. The patient non-transport algorithm should be utilized anytime a non-transport is being considered. Any checkmark in a shaded area, also known as a gray box finding, requires contacting online medical direction for guidance prior to terminating the patient encounter. For example, if the patient has a chief complaint of chest pain, shortness of breath, altered mental status, intoxication, or head injury, you have hit a gray box, and you must contact medical direction for guidance prior to terminating the patient encounter. If the patient has abnormal vital signs or glucose that are too low, such as a glucose of 40 or a systolic blood pressure of 70, you have hit a gray box and must contact medical direction prior to terminating the patient encounter. If the patient has abnormal vital signs or glucose that are too high, such as a blood glucose of 400 or a systolic blood pressure of 210, again, you have hit a gray box, and medical direction must be contacted for guidance prior to terminating the patient encounter. All care provided on a non-transport call and the decision process for non-transport must be documented carefully in Siren. Patients who refuse care must sign the refusal form. The non-transport algorithm and patient signature may be documented in Siren. Alternatively, EMS may utilize the paper form, which will continue to be made available to agencies who prefer this format. Resuscitation initiation and termination. Please note that the resuscitation initiation and termination protocol has been updated to require that medical direction be contacted prior to the transport of a patient in cardiac arrest. Let's review the adult termination of resuscitation or TOR rule for adults. Assess for arrest not witnessed by emergency medical services personnel. No return of spontaneous circulation after 20 minutes of either BLS alone or combined BLS and ALS in the absence of hypothermia, and no shock delivered or advised by the AED. If all criteria are present, contact medical direction to consider termination of resuscitation. If any criteria are missing, contact medical direction to consider termination of resuscitation or continued resuscitation and transport. If return of spontaneous circulation, ROSC, continue resuscitation and transport, and contact medical direction. Notify law enforcement if terminating resuscitation. Remember, if transport is initiated, resuscitation must be continued until arrival at the receiving hospital. Pediatric patients are not included in this adult TOR rule. Most pediatric patients will be transported. On occasion, it may be appropriate to terminate a pediatric code on scene depending on the situation. Either way, always contact medical direction to discuss pediatric codes. Also, please note, this is Vermont. It's cold. The TOR protocol cannot be applied to hypothermic patients. As we all know, you are not dead until you are warm and dead. Hypothermic patients without contraindications to CPR should have continued CPR and should not be considered for TOR until the core temperature has been rewarmed, which you will not be able to do in the field. Hypothermic arrest patients are not candidates for TOR and should be transported to the emergency department for rewarming. See the full environmental hypothermia protocol for review. Also note, patients who have CPR-induced consciousness should not be considered for termination of resuscitation. Safe Response and Transportation Guidelines. This new protocol reviews safety transportation practices for EMS. It limits lights and sirens to time-critical emergencies such as MI, stroke, or multi-trauma. Determine transport priority considering the road and traffic conditions as they may impact the potential time savings, the ability to perform effective patient care, and most importantly, the driver's ability to safely transport with lights and sirens. Consider flow of traffic transport for cases such as cardiac arrest due to the inability of providers to be properly restrained when performing CPR, unless traffic conditions would significantly prolong transport time. Please review the full new protocol. Strangulation. This new protocol addresses the unique traumatic condition of strangulation. Strangulation is defined as asphyxiation caused by the closure of blood vessels and/or air passageways of the neck due to external pressure. External pressure can be manual via a body part such as hands, arms, knees, or can be by an object such as a belt, rope, etc. Patients are at risk of delayed death due to internal swelling, anoxia, hematoma, or structural damage that cannot be identified externally. Patients suffering strangulation episodes should be encouraged to seek medical care. If transported, communicate reported strangulation to the hospital staff. There are many signs and symptoms of strangulation. Please review this diagram for more information. Victims of violence. This protocol replaces Protocol 8, Abuse and Neglect Assessment, and Protocol 8.16, Management and Response to Domestic Violence. Phone numbers and statutes have been updated. The protocol addresses sexual assault, human trafficking, domestic violence, child maltreatment, and vulnerable elder adult maltreatment. Please review the complete new protocol. This concludes the training module on the 2020 Vermont Statewide EMS Protocols Medical Policies.